We are starting the genitourinary tumor and sarcomas. The first speaker is Dr. Srilikuri Srinivas. We know him very well, and so I am welcome him to deliver his talk on proton therapy for musculoskeletal tumor, therapeutic advantage, and APCC experience.
Thank you, Dr. Biplab. So I am very happy to present today proton therapy for musculoskeletal tumors. I think there is a fair bit of consensus about the benefits of proton therapy for large musculoskeletal tumors. But I am very happy to announce our experience. I am happy to present our experience, our initial APCC experience on using proton therapy for these unique set of tumors. We have recently published this commentary about proton therapy in low and middle income countries, and we argued why is it needed even in the setting of lower and middle income countries in the context of higher costs and higher infrastructure requirements. But we have written clearly that there could be a great benefit for a few, semantics aside, incremental benefit for some and not much benefit for many. But musculoskeletal tumors at least fall into the category, apart from many other tumors, into those with a large amount of benefits. And the reason is there is a physical advantage, and which is probably the biggest reason why proton therapy is one of the key or preferential treatment modalities in musculoskeletal tumors, which is lower physical doses to normal structures. We know about the physical advantages. Typically, the higher doses to the normal structures actually receive lower doses than compared to conventional radiation. You can see here, this is the proton plan, this is the VMAT and the helical tomotherapy plan. And the intermediate doses, you can see over the pelvic structures, the marrow, the pelvic organs. The intermediate doses to normal structures actually derive maximal benefit, where you could potentially deliver almost no dose with proton therapy. Apart from the physical advantage, there, if at all, if we consider that we believe that radiobiologically protons seem to be more effective or more higher biological effectiveness compared to X-rays, and there is clearly only benefit for us in case there is an RB benefit, an RB advantage, which we are learning clearly that there seems to be clear advantage biologically as well. So I think these are this is the reason: higher biological dose to the tumors and lower physical doses to normal structures, and these are the most important reasons why musculoskeletal tumors benefit greatly with proton beam therapy. And the fact that most of these tumors biologically also, they have unique features. You can see chordoma, chondrosarcoma, or unresectable soft tissue sarcomas, or osteosarcomas, not very typically radiosensitive, chemosensitive, need large doses for effective control. And most often there are, when they are referred for radiation, they are in critical location, and including those patients who have chemosensitive sarcomas, such as Ewing's and rhabdomyosarcomas, round cell tumors, which are radiosensitive, but there seems to be, even in those patients, there seem to be some benefit with escalated doses, as shown in the recent studies. And the fact that most of these tumors, when they are referred to radiation oncologists, they are large volumes, and they come to us when they are unresectable. They are recurrent when the surgeons don't want to reoperate again, or after reoperation, or in younger population. I think all three, they are well-known advantages of proton. The larger the volume, larger is the benefit with protons. Recurrent setting, younger population, I think all these seem to be good indications why of proton therapy. Apart from all these, we all know that these tumors are located in difficult locations, and we have sensitive neural structures, cord, brainstem, chorda equina. Apart from that, we have bowel, and you name it, literally, because we are giving very high doses, we have a large number of organs at risk, and all these OR constraints we use on a day-to-day practice to make sure that they receive less doses within the tolerance limits of these structures. Summing up our experience of proton therapy for musculoskeletal tumors, we have treated close to 120 patients of musculoskeletal tumors, chordoma and chondrosarcoma being almost half of them, Ewing's, osteosarcomas, soft tissue sarcomas, RMS including pediatric and adult, and we have treated 2 patients of plasmacytoma as well. And there are, of course, apart from these, there are aggressive fibromatosis which could be used, and of course I have not written SFT, which is solitary fibrous tumors, which we have treated in 1 patient as well. So we are hoping to initiate this registry very soon, which is sarcoma, chordoma, chondrosarcoma, prospective registry. We are hoping that this registry will be able to prospectively assess the outcomes of patients in an umbrella fashion. A large group of indications can be combined together, because most of these require large doses. They are in critical locations. The doses required are very, very similar, and so we are using PFS as the primary objective, and of course the toxicity. Therapy response, we are looking at unique ways to capture therapy responses, not just with the typical, we know, RECIST, WHO. There are also other criteria such as CHOI criteria for sarcomas. So we are looking at other means and ways to, apart from the molecular imaging, metabolic imaging using DCE, MRI, and radiological kinetics, we are looking at unique response assessment tools for these tumors. If you see for chordoma and chondrosarcoma, which I mentioned, which constitutes more than 50% of our tumors, the standard of care is en bloc resection, R0 resection, but it is easier said than done, because again, these are spinal, paraspinal tumors, skull base. Because of the difficult location, R0 resections are rarely possible. And if R0 resection is not possible, what else happens is R1 or R2 resections. And consistently, long-term studies have shown in patients who undergo R1 and R2 resection, that the outcomes, this is for skull base and cervical spine, is in the 10s and 15, close to 10-15%. For sacrum and thoracolumbar spine, slightly better, but still around 30-35%. So long-term outcomes with surgery alone are dismal, especially in the context of R1 and R2 resection, which are probably the predominant kinds of surgeries in these group of patients. And there are now multiple prospective and retrospective studies which have shown that long-term outcomes, if you see 7-year local control, about 70% for chordomas and 90% for chondrosarcoma, consistently seen across several proton studies, both for skull base as well as the mobile spine and the sacrum. So you can see this is the typical ballpark figure, 70% for chordomas in proton therapy series. I think, again, most of them are a mixture of patients, large volume, small volume, contaminated, R1, R2, R0 resections. So these are all comers, and despite that, about 70% of them have long-term local control. I think there is a fair bit of consensus, and the consensus stems from the fact that a lot of studies, small and big, short and long studies, have essentially shown that there is a distinct advantage of using proton therapy for all these tumors. And the difference is between around 75 versus 19%, that kind of difference. And although this NCDB analysis we know comes with a lot of potential biases, but the fact that the difference is so much, it clearly gives a signal that it seems to be definitely better compared to X-ray based radiation. In fact, to an extent that the SACRO trial, which is one of the few randomized trials in chordomas, which is a very rare tumor, it's not randomizing between proton versus photon. It is actually randomizing between proton versus surgery, which is an interesting study. It is not just incorporating, it's kind of a pragmatic study where it is just not just a randomized trial, but randomized and an observational trial. Observation trial, which prospectively, a prospective cohort, just an observational study whether patients undergo surgery or proton therapy, they are prospectively observed, prospectively assessed, and of course there is a randomization cohort also between proton versus surgery, and let's hope that this will also answer some of the questions which we tend to ask in these challenging patients. So we have seen quite a few challenging cases at APCC. As you know, that most patients, we receive almost 1 to 2 chordoma chondrosarcoma inquiries every week. So essentially, it's one of the most common tumors which we treat at Proton Center because of obviously the availability of so much data. But the fact is, we see most of patients come at the time of recurrence. After initial surgery, the patient recur. Either they have already received radiation once or not received radiation once, but they come like this with diffuse recurrences after debulking surgeries. This is one of them. This is another. You can see initially it was so nice. This tumor could have been treated very well, but you see the odd location of these recurrences. Another diffuse recurrence. You see the diffuseness of the recurrence, and it is all over the place in many muscular planes. Again, another major. You can see that there is a diffuse recurrence. So, apart from the fact that these are diffuse, the post-operative volume becomes almost 4 times the preoperative volume. Essentially, even the preoperative volume itself is large because we give a margin of 2.5 to 4 centimeters sometimes. And in post-operative setting, we tend to be more conservative in terms of giving margin, more aggressive in terms of giving margins. We tend to give larger margins in post-operative because there is so much of potential post-operative contamination that we give very large volumes, and therefore the toxicity could be significantly higher in the post-operative setting. This was one of the first cases we treated. Again, after surgery, patient was fortunately not irradiated, but a diffuse recurrence. You can see a pararectal nodule. There is a nodule very close to the skin. Operated, debulked, and this is the story of our typical initial experience. From the day one, we decided that this will be our dose fractionation regimen for chordomas. We chose to give close to 76 gray or 74 gray, so tier 1, tier 2 dose whenever possible, 72.6 in 33. We have been cautious to begin most of our patients with 70.4 in 32, which has been our go-to fractionation regimen for most sarcomas, including chordomas and osteosarcomas as well. And tier 1 dose we have reserved. We started with this for microscopic disease, 64 in 32, wherever feasible. Wherever the volume is limited, we go up to 64 gray. But sometimes we have used 57.6 in 32 as the microscopic dose as well, which is 1.8 gray per fraction, assuming an alpha by beta for chordoma as 2. Another challenge is the response assessment in sarcomas. We know not just in chordomas, but in all sarcomas, we do not see clear evidence of reduction in the size of the sarcoma, so size of the tumor. The imaging abnormality does not immediately shrink in size, unlike RMS or Ewing sarcoma, where the responses are more dramatic. And so we see a very gradual reduction in the size, and that is why we take help of PET scans, MRI characteristics, the T2 weighted abnormality, the DCE MRI perfusion. All these are being taken into account for assessment of response, and there is no consensus regarding what criteria to use as a response assessment tool, and this is one of my research interests as well. This was one of the first patients. Patient was unable to lie down prone nor supine, kind of a miserable in terms of pain. We have treated this patient in a very odd lateral position, but the setup was perfect. We could reproduce this position throughout the treatment and made sure that you can see that the isodose curves are very, very impressive in terms of sparing normal structures in the pelvis. This was how we used our DC MRI to assess response. And of course, we have also used PET. This is post-proton, 2 years follow-up. The patient is still locally controlled. This is also one of our early patients. I'm showing these patients because we have long follow-up now. This is a gentleman from Himachal Pradesh, came with a large tumor, had a small, mild limp. He was constipated. He was using laxatives. Bladder, fortunately, was not so bad. He was able to pass without much neurogenic symptoms. And this is the February 2019 scan, the initial baseline at the time of planning. August 2019, you can see after 3 months, there is some kind of a regression in the size. And of course, in January 2020, there is some more regression, some further regression. but obviously the patients are not convinced that is it responding, is it really good. So we use DC MRI. You can see the lack of perfusion in this, and this could be a surrogate for early response, because we actually correlated this with a 2022 JAN scan. You can see the same patient, significantly smaller tumor. I think this is literally the magic of large doses of radiation, able to walk with a limp, very similar limp, occasional analgesics because of the sacral plexopathy a little bit. Other than that, he's able to manage without analgesics. He still continues to be constipated, but bladder is still functional. So, we were satisfied with the outcome of this patient last 2.5 years. Similarly, dorsal chordomas, I am very, very skeptical, especially when the intraoperative notes say that peritoneal pleural contamination, then you have to treat the entire pleural cavity. But fortunately, in this patient, well operated, pleura was not breached, so we were able to treat this dorsal chordoma effectively with very less doses to the mediastinal structures. Our neurosurgeons, credit to Dr. Rupesh and his team, where you can see that this is a tumor which is abutting the cord, and we were able to debulk this area and put fat globules. You can see the fat globules which separates the tumor from the cord, so that we can effectively give very large doses to the tumor. And this has been done in number of patients already. Also, we face a huge number of patients with metal implants. It is not very uncommon at all. You can see, you see nothing. Literally, you see nothing. You don't know whether tumor is there, how much of it is there, whether it's close to the cord or not, how to spare the cord. How to assess response in these patients, because you can see the video, you can see that you can see nothing in the area where the implant is kept. And this is another challenge which we face. It's already been shown across multiple studies that patients with implants don't tend to do very well with protons. Of course, these are old literature. This is before we had in-depth understanding of newer proton planning methods, and of course, at our hospital, we have a very detailed workflow, credit to our medical physics team, which is extremely meticulous in understanding and to mitigate the uncertainties. We take a plain CT, we do a single energy metal artifact reduction software. You can see significantly lower artifacts in these patients. Apart from using CMER, we also MVCT. Fortunately, we have helical tomotherapy at our hospital. And we do it routinely in all our patients. We capture orthogonal X-rays. Even all these tend to either over or underestimate the size of the implant. And this is where we use exact dimensions. We take it from the surgeon, because all these are literally made by multiple vendors. We contact them sometimes to understand the material, the density. And of course, we need that to assign appropriate Hounsfield units to these material. We do a 3D reconstruction of the implant, and then we have multiple solutions during the planning. We use multiple proton fields, not 2-3 fields typically what we do, and we avoid fields along the long axis of the implant. We use a combination of photon and proton. We use everything with the knowledge of material and understanding its physical characteristics. Of course, we use Monte Carlo algorithm from the day one for optimization algorithm, not just for these patients, but for all patients. There were certain patients where after repeated surgery, sometimes patient comes and refuses any more surgeries, and you can see the tumor is still abutting the cord, and this patient has already received previous radiation, so double trouble literally. And we have been able to treat this with hyperfractionation. Of course, that tends to slightly reduce the probability of long-term effects onto the cord. This patient has been treated on 72 grain 60 fractions and 1660, and the patient is so far doing reasonably well with no toxicities. We have presented our initial experience, and we have noted a very low rate of acute grade 3 toxicities. In our limited experience, those who had more than 1 year follow-up, again, have very few grade 3 toxicities as well. Despite our tumors being very large, diffuse recurrences, recurrent tumors being one of the common ones. Coming to osteogenic sarcoma, this is one of the studies which is often quoted from Tom Delaney's group. Dr. Tom Delaney is speaking after my talk. They have demonstrated 72% excellent 5-year local control and disease-free survival of about 67% with acceptable grade 3-4 toxicities in osteogenic sarcoma. Unfortunately, as radiation oncologists, we receive the worst of worst OGS. Large volume disease, unresectable of course, poor chemo response when surgeons do not want to operate, very challenging locations such as pelvic, vertebral, mandibular, skull base. These are extremely challenging locations. We have tumor thrombus, again, surgeons not willing to operate those patients with tumor thrombus. These are the kind of the worst prognostic subgroup which unfortunately come to us as radiation oncologists, and we have to treat them. And this is one of the such patients with a young child who had presented with osteogenic sarcoma. You can see a large lesion. We could spare the bowel, ovaries, and the pelvic structures. We could deliver up to 74 gray equivalent of radiation. In fact, with concurrent chemotherapy with cisplatin, because we omitted the methotrexate, but we continued the cisplatin during the radiation as well. This was another patient, very challenging, just delivered a 3-month-old baby, diagnosed with OGS, with tumor thrombus, received neoadjuvant chemotherapy, not much of response. And you can see that there was a tumor thrombus beyond the iliac bifurcation. And this was, again, the reason why the patient was not suitable for surgery. And we have treated this patient and, again, treated the whole tumor thrombus as well. And very, very gratifying to see at 6 months, there is a significant regression in the tumor thrombus as well. And this, again, is a testament to the fact that when you give very large doses safely, these tumors tend to have reasonably good local control. The patient continues to be systemically controlled as well. This is another osteogenic sarcoma which we treated very early into our practice. You can see large pelvic osteosarcoma. I think that Dr. Manish Agarwal's patient, and you can see that we could deliver very high doses. This is pre-proton. December 2020 already significant reduction, and the patient continues to have reduction, and the patient still is under follow-up and is doing reasonably well. In patients who have unresectable sarcomas, again, that is a very good indication for proton beam therapy. This was an IVC sarcoma. It was not a large one. This patient was received after neoadjuvant chemotherapy for 6 cycles, and we could deliver very large doses. Duodenum was actually stuck to it, and we could still give 66 in 30 to the gross tumor volume and 60 to 30 in the microscopic disease. Patient remains well after 30 months of proton therapy. Again, you can see that there is no uptake and an anatomical metabolic regression of the tumor. Again, very large 85-year-old high-grade sarcoma, very close to the vessels, and this is the reason why margins could be positive. So we could deliver very high doses, 60, 70 grain, 33 fractions to this area where the margins could be close. And this is the place where we could deliver 66 in 33. And in the places where it is very close to bowel, we gave 1633. So we could tailor the doses based on that. And patient completed treatment without any acute GI or GU toxicities. Another recurrent sarcomas which we treated in the axilla, patient received 2 times radiation, once brachytherapy, operated twice, operated thrice. You can still see the seroma below the tumor, and infiltrating the brachial plexus. We could deliver very large doses again in this patient, slightly underdosing the area around the brachial plexus. And you can see the response. This was the pre-treatment, and this is the post-treatment. Patient continues to remain well after nearly 1.5 years, both locally and systemically controlled. Ewing sarcoma, again, very difficult location, pelvic and vertebral Ewing sarcoma. We have treated a significant number of them. We have treated including those patients with lung metastasis where lung bath is given after chemotherapy response. And we could treat both the primary site as well as lung bath in the same setting with breath hold with 55.8 gray to the gross tumor and 15 gray to the lung with a mean hard dose of 5 gray. I think this is very, very remarkable. I have not deliberately, because of the lack of time, I've not gone into rhabdomyosarcoma, but I can conclude here, particle therapy has a significant role in almost all of MSK tumors wherever radiation is indicated. Upfront proton therapy has been shown to significantly better outcomes. There's a tendency that, okay, let's give radiation 60 gray and then send for proton later if it recurs. And that is actually, the data clearly shows that in recurrent setting, the outcomes are actually very significantly inferior. Despite large volumes, difficult locations, re-radiation, recurrent setting, what our experience has been, the toxicity is quite acceptable. Underdosage of the tumor causes tumor failure in more than 2/3 of patients, especially in chordomas, and hence proton therapy is very, very important. It's not that I have been able to give, but you have underdosed. But if you have underdosed significantly, there is an increased probability of recurrence. High OIR constraints, crucial for better outcomes, and slow radiological responses are a norm. Longer follow-up is needed for survivorship issues. This is our team, the musculoskeletal team. Dr. Sujit and Dr. Vishnu are our medical and surgical orthopedic oncologists, without whom we could have not treated all these patients. Of course, my colleagues in the Department of Radiation Oncology, special mention to Dr. Sham, who has been my colleague and has helped me since almost all these patients were jointly treated by me and Dr. Sham. And of course, our greatest thanks to our patients and their ever supporting families. Thank you very much.
I can speak.
Yeah.
Hello. I think it is a nice talk, and it is a very informative talk, and I have some information got it from the sarcomas and all these things. This is in a general setting also, in a photon also, it is always a challenging task to do. So is there any questions, or in the chat box if there is something, so we can just go ahead. Anybody have any question? I have some questions, but we can go after somebody. Dr. Goidala? Dr. Manish?
Yeah,
Please.
Dr. Manish, please.
Yeah, so I think it's an excellent talk and a real eye-opener for all of us, because there are so many situations that we face where we really don't have answers in surgery. And this is where the proton beam comes in. So my question, Dr. Srinivas, for you is, if you're going to treat soft tissue sarcomas with preoperative radiation, would there be an advantage of using protons over the conventional radiation that we are using? Both in EVs as well as in soft tissue sarcomas, where more and more often now we are using pre-op radiation rather than post-op radiation.
Yes, sir. I think the role of proton therapy in soft tissue sarcoma, especially in the preoperating setting, would only arise if we are talking about difficult locations, challenging locations where the resectability is borderline, maybe in the setting of retroperitoneal sarcomas, or in locations where the tumor is very close to the vascular structures or neural structures, paraspinal locations. Those are the typical locations. Of course, in extremity sarcoma, there would be very little benefit of using proton beam therapy, irrespective of whether it's pre-operative or post-operative setting, unless it's a very young child. So in retroperitoneal sarcomas, we have seen that you could deliver much larger doses, especially in locations close to vessels, where our surgeons would be, for surgeons it would be challenging to achieve margin-free resection. So I think that is the typical indication where we would consider proton beam therapy.
So, Dr. Srinivas, I have one more question, is that when you're treating, like you showed in that osteosarcomas of the pelvis or for the spine, how late do we need to watch them for recurrences? When can we say that now the amount of follow-up or screening that is required to look for recurrence can be now relaxed a little bit?
Yes, sir. I mean, that's a good question. I think my understanding is, if you have occult metastasis already, we do see some lung nodules once in a while in patients of osteosarcoma at baseline, which may or may not disappear after the initial course of induction chemotherapy. My worry is the first 6 months to 1 year, if you are seeing a lung nodule, Probably that was a poor patient selection on our part to go for proton therapy or for aggressive local therapy, although it's reasonably justified to give a good local control. But the fact is, those are the ones which recur early, after 6 months or 1 year. But if you see that if you are okay for about 1 to 2 years, then we are slightly better off. Then probably we have selected our patients well for a high dose therapy. Even if we have given a little bit of grade 3 toxicity, it is justified because we are giving some kind of a control, disease control in those patients.
Just two small couple of questions with the permission of chair. Because there are so many people, logged in, 300-400 people, for the benefit of all the audience, the lower sacral or lumbosacral chordomas, there is always this debate whether you should operate upon them or just do a biopsy and upfront proton. And then I have one more question.
Well, traditionally, the gold standard is still surgery, but surgery has to be R0 resection, wide resection, which is not always possible. Of course, S3 and below, I'm sure Dr. Agarwal would agree with me that S3 and below, the lesions are amenable for wide excision. Still, there is a risk of neurogenic bladder in those patients as well, but it is possible to do a very good surgery in those patients. And patients who undergo R0 resection have excellent outcomes, excellent long-term outcomes. But any sort of R1 or R2 resection is actually detrimental to the patient. I would say radiation would be slightly better in our experience. As I showed, the postoperative volumes are larger, the toxicity is more, because possible contamination is more. So and that is a subject of the SACRO trial as well, that it's a randomized trial between surgery and radiation, whatever form it is being done. But it will give some answers in going forward, what is the role of surgery or what is the role of proton upfront after a biopsy.
Right.
We have treated a few patients only after a biopsy.
Yes, and they showed very good response. Thank you. One final question, because I'm slightly more towards the CNS group, and we have such wonderful experts, including Dr. Delaney, Dr. Agarwal, Dr. Laskar. Why is it, I think we have discussed it once or twice, but is there any recent update? The skull-based chordomas are significantly worse than chondrosarcomas, which have more than 90%, while the spinal chondrosarcomas do worse than chordomas.
I think because of the volume. And probably biology as well.
Is it just the volume? Because
probably biology as well. Skull-based chondrosarcomas tend to be smaller, detected earlier because they come with neural compression earlier. Chondrosarcomas, pelvic ones, are huge ones.
Okay.
And especially the ones which we treat are the ones which are unresectable in the pelvic location in large volumes. Dr. Delaney also probably can comment on that.
Sorry, we can't hear.
No.
I'm afraid, yeah.
Dr. Delaney, you are
Yes,
muted.
I would agree there's a very significant difference in volume. The skull-based chondrosarcomas are really quite small, whereas the ones we treat in the pelvis and the spine tend to be quite large.
Okay, thank you.
So, I have this. Yeah.
Can I
Dr.
have?
Srinivas, can I ask one question?
Yes, sir.
Dr. Srinivas.
Yes, please go ahead,
Dr. Srinivas, as you said that many at times you get, treated earlier with a photon and then they are coming to you after the recurrence. So do you think that is there any change in DFI when you can give re-irradiation to these patients? Because many at times you get patients from outside. So how do you manage these kind of patients?
Yeah,
giving
that's a really good question, because that is the challenge which we face day in and day out, because patients receive 50 gray or 60 gray to a chordoma and then are referred to us for treatment, and the DFI is typically 1.5 to 2 years. It definitely remains a challenge because the amount of dose which we can deliver in the re-radiation setting tends to be lesser. The volume which we can treat is also tend to be lesser. We tend to be slightly conservative with volumes. And if we treat larger volumes, there would be higher toxicity. So it is a challenge which we face every day treating these patients in the recurrent setting. And unfortunately, we do see those patients much more than patients which are pristine, just a very good surgery done, and we are being referred for adjuvant, or just a biopsy and referred for proton therapy?
It's a small questions. Like, I think debulking followed by the proton will, do you think that will have a better?
So that's what, Dr. Daya, that debulking is something which, I mean, if the tumor is compressing neural structures and the patient is symptomatic, we do not have any option that we have to debulk. If the tumor is abutting the neural structures also, we have shown that there is benefit of debulking, because I can probably push in more doses in those patients. So other than that, I think debulking should be limited, because that will increase the toxicity significantly, because we tend to treat larger volumes.
I agree.
Okay, thanks for a nice talk, Dr. Chilikuri. I have one small question. That you showed a 3-month-old girl do deliver radiation therapy for 3-month-old girl. I mean, if
No, 3 months later.
Oh, okay. So I missed. No. So in a radiation setting or in a upfront radiotherapy also, see, for example, the tumors which is affecting the spinal cord or any other serial structure, is there any role of increasing? Is it possible? First of all, is it possible to increase the dose? I mean, increase the tumoricidal dose, avoiding the.
No, it is challenging. If it is abutting the cord or abutting the neural structures, it becomes very challenging to deliver very large doses.
Okay, I mean.
Even with protons, there's no doubt about it. Even with protons.
Even with.
Yes, absolutely.
Okay, right. Thank you.
So, and can we start another one?
Yeah,
Srinivas?
our next speaker is Dr. Professor Thomas Delaney, and he will be discussing about the proton therapy for challenging sarcomas. Over to Professor Thomas.
This afternoon, I'll be discussing proton radiation for challenging sarcomas. Slide here illustrates what I think are the indications for the use of protons for sarcomas. These include pediatric sarcomas, bone sarcomas, skull base, spine, pelvis, retroperitoneal sarcomas, selected extremity, trunk, and visceral sarcomas, as well as the setting of reirradiation. I will not be discussing pediatric sarcomas or skull base sarcomas, as those will be discussed in another presentation. This slide illustrates visually the difference between intensity modulated protons to treat a paravertebral sarcoma and intensity modulated X-rays. You can see the clear and obvious difference in the exit dose. The structures anterior to the target volume here with photons that you're spared with the use of protons. Focusing first on bone sarcomas, I want to share a case with you of an 18-year-old woman I treated with a sacral osteosarcoma. She received standard neoadjuvant therapy, then underwent concurrent chemoradiation with ifosfamide and etoposide using protons to deliver 45 gray RBE to an elective clinical target volume that included the tumor and about 1 centimeter of margin to account for microscopic extension beyond gross tumor, followed by a boost to gross tumor to 72 gray, all given at 1.8 gray per fraction. She remains disease-free 12 years after treatment with this very large pansacral sarcoma. We managed to spare her uterus and her ovaries. She has normal ambulation. She's pain-free, off medication. She's working full-time. And because we were able to spare her ovaries, she resumed menses 1 year after the end of chemotherapy. And this just illustrates her proton plant. Here, she was treated prone, which allowed the uterus to fall forward and enhance the sparing of the uterus. Frank Siernick, a fellow with us, put together our experience with the use of protons for osteosarcoma. In this scenario, we had 55 patients, and 2/3 of the patients had primary tumors, and about a third had a locally recurrence, a handful of metastases. Most of these, as you would expect, were in sites that were not amenable to a wide or even a partial resection, craniofacial tumors, as well as tumors involving the pelvis and the sacrum. In these cases, about a fifth of the patients had a biopsy only. 43% had positive margins after resection, and about a third had had an incomplete resection. The median dose was 68.4 gray, and nearly all patients, as you would expect for osteosarcoma, also received chemotherapy as a component of the treatment. And the local control at 5 years is really quite respectable, 72% again for osteosarcoma. It's a very challenging location with a survival that was comparable at 67%. What I'm going to do now, I'll just move on to a prospective study that we performed in patients with spine sarcomas. This was published most recently in 2014 in the Journal of Surgical Oncology. This study accrued 50 patients between 1997 and 2005. These patients were treated with proton-based radiotherapy with or without surgery. The majority of patients had either chordoma or chondrosarcoma. The locations, as you would expect, a substantial proportion of patients had sacral tumors, and 36 of the 50 patients, about 3/4 of the patients had primary tumors, and 14 patients had locally recurrent tumors. Our standard dosing for the initial clinical target volume, 50.4 gray and 28 fractions, a boost to the tumor bed in patients who had resection to a total dose of 70.2 gray, and in patients who had gross residual tumor, unresected tumor, the boost was then carried to 77.4 gray. This study was done with passively scattered protons, and again, the results really are quite encouraging. The 8-year local control for primary tumors, 84%. Unfortunately, recurrent tumors only about 50%, emphasizing that for high-risk patients, you should really try to treat them at the time of initial presentation, as salvage is less successful than treatment at the time of the original presentation. And again, overall survival about 2/3, and this was done with only a 13% risk of grade 3 or grade 4 radiation therapy complications. Based on the study, we felt that high-dose photon-proton radiation was an effective treatment. The results appeared durable with only occasional late recurrences. As I mentioned, we prefer to radiate high-risk patients at the time of initial presentation rather than trying to salvage them at recurrence, as salvage rates are only about 50%. The morbidity appeared to be quite acceptable. We had no late myelopathies. We did have sacral nerve toxicity in 3 of 25 patients who received 77.4 gray, but it was uncommon, and this was generally in patients who otherwise would have had an upper sacrectomy with 100% risk of neuropathy. But just illustrating our next protocol, which was a protocol of scanned protons for patients with spine and sacral chordomas and chondrosarcomas. This study completed accrual of 60 patients in June of 2017. Again, similar dosing with as was used in the prior study, with GTV was carried to 77.4 gray. Tumor bed was taken to 70.2 gray after resection, and the initial clinical target volume went to 50.4 gray. We presented these initial results at Astro a couple of years ago with a 2.5-year local control rate of 93.5%. And my colleagues at Mass General are now discussing the next study, which is likely going to be a dose-painted, simultaneous integrated boost study with 28 fractions, delivering 50.4 gray to the initial CTV, but then carrying the GTV to a dose of about 70 gray at 2.5 gray per fraction. This next study was published in Journal of Neurosurgery Spine in 2015, and looked at there's a retrospective look at a large cohort of patients treated with high-dose proton-based radiation therapy, with or without surgery, and the management of chordomas. Again, spine and sacral chordomas. We had 126 patients with 127 lesions. This study just focused on patients with thoracic, lumbar, and sacrococcygeal tumors. And what we learned from that study, again, was that local control is higher in patients who are treated for primary rather than recurrent tumors. The 10-year rates of local control for primary tumors, 52% compared to only 42% for patients who have recurrent tumors. We also noted that for patients undergoing surgery, local control is improved with an en bloc rather than intralesional resection for these resectable chordomas. And one very interesting finding that emerged from this study was we compared patients who had a component of preoperative radiation compared to those patients who had exclusively postoperative radiation. These patients receiving preoperative radiation received something between 19.8 gray and 11 fractions initially for sacral tumors, whereas mobile spine tumors received 50.4 gray and 28 fractions. But over time, as we improved our plastic surgical techniques for a wound closure in the sacrum, we went to 50.4 gray preoperative radiation for sacral chordomas as well, with an attempt to spare subcutaneous tissue to reduce the risk of wound healing, as well as use of complicated flaps to improve healing of the sacral wounds. But it was a marked difference in local control between patients receiving a component of preoperative radiation with a 10-year local control of 71% compared to only 37% in patients who received no preoperative radiation. And in fact, we had no local failures in 28 primary patients who had what we felt to be optimal treatment, had a core biopsy, preoperative radiation, en bloc resection. And because it was so effective in that patient population, we've reduced the total dose if the surgical margins were negative from what was initially 70.2 gray to then 68.4 gray, and we had no local recurrences at 3 years. We modified the protocol to allow reduction in total dose to 64.8 gray, and excellent local control has been maintained in this patient population. And again, just to emphasize how much, not only how much more effective it is, but in terms of morbidity, the use of preoperative radiation avoids this scenario with postoperative radiation, where this sacral chordoma, once it's resected and you're doing exclusively post-op radiation, you have a bowel that's herniated right into the target volume. And this provides an excellent rationale for a component of preoperative radiation. And from a surgical point of view, the surgeon should try to use a omentum or a flap to displace the bowel from the intended radiation field. And so our current recommendation is preoperative radiation 50.4 gray, 28 fractions for the mobile spine. And initially we had used a 19.8 gray and 11 fractions for the sacrum, but we're now using 50.4 gray if we have a flap closure to reduce the risk of wound healing problems. There are patients, however, particularly those patients who have tumors of the upper sacrum, where resection entails loss of bladder and anal sphincter control, as well as a loss of erectile function in men, as well as perineal anesthesia in women. And so a number of patients really are not prepared to accept the morbidity of an upper sacral resection. So we've accumulated a number of patients we've treated with definitive high-dose proton-based radiotherapy for unresected spine and sacral chordomas. We recently put together this experience, and it's been published in radiotherapy oncology with Walter Banfield as the first author. And of these patients, 42 of them decided against resection because of concern regarding loss of neurologic function. 13 patients declined surgery for other reasons, as well as patients being medically inoperable. Relatively typical chordoma cohort, slightly more men than women, median age in the 7th decade. predominance of patients who had upper sacral tumors. 52 of the 67 patients had sacral tumors. The majority of patients had primary disease. A small number had oligometastatic disease. At presentation, median size 7.4 centimeters. And at this point, we have nearly 5 years of follow-up on these patients. So this is a reasonably mature series, again, illustrating in this case, patient with a locally advanced sacral chordoma that was treated with definitive scan beam radiation. Got some very nice sparing of the subcutaneous tissues here. And this is another patient we had treated with a C2 chordoma. And again, note from a treatment planning point of view, we use intrathecal contrast in these patients who have tumors that are abutting the dura at a spinal cord level to allow us to visualize the spinal cord in high definition. We've used this technique for a number of years, and has allowed us to take these paraspinal tumors to quite high dose. And again, this is a patient who was treated for a C2 chordoma, and she declined surgery. In our local control are really quite excellent. The local control at 5 years, 81.8%. There is a fall off though, even after 5 years, and at 8 years, down to about 64%, but it really doesn't seem to go much further below that. So able to get local control in about 2/3 of these very challenging patients. When we did a statistical analysis, we noted that patients who received higher doses of radiation, 78 to 85 gray, and these doses were actually normalized to 1.8 gray per fraction because there was some range in the doses that were used. That patients were treated between 1.8 and 2.5 gray. So this is what the dose normalized to 1.8 gray daily, and patients who had 78 gray or higher had improved local control. So for these patients now, we're actually treating them to 79.2 gray if they're being treated at 1.8 gray per fraction. And again, this was a trend with a p-value of 0.09, showing again the likelihood of local failure decreasing as the total dose increased. Again, these are statistics here. About 30% of patients will develop distant metastases. It's high-risk population. Between distant metastases and local failure, chordoma-free survival, unfortunately, only about 45% at 8 years, but overall survival about 2/3 at 8 years. This was done with no spinal cord injuries. Sacral insufficiency fractures occurred in 15 of the 52 patients who had tumors arising in the sacrum for a rate of about 30, just under 30%. So, as you would expect, a few cases of radiation proctitis for tumors in the sacrum, but no significant fibrosis. And we had 5 either spinal or sacral neuropathies. And these were usually in patients who had upper sacral tumors, who, if they had undergone resection, the risk of neuropathy would have been 100%. These results look very similar to the results you can achieve with carbon ion, and the group in Heidelberg is currently randomizing patients with skull base chordomas, as well as sacrococcygeal chordomas, to either carbon or proton with slightly different fractionation schemes on these two schedules. You can look at the details of these studies at clinicaltrials.gov. Just a few words about retroperitoneal sarcomas. The recent Strauss study, a sensitivity analysis, showed that there was a suggestion of improvement in relapse-free survival in the patients who received preoperative radiation compared to surgery alone, with about a 10% improvement in abdominal relapse-free survival. And then when you look at the rate of local recurrence after macroscopic complete resection, 30 in the surgery arm compared to only 12 in the preoperative radiation arm, suggesting that preoperative radiation does improve local control in this population. Nevertheless, because of the significant number of patients who are still recurring after 50.4 gray of preoperative radiation, we embarked within a group of institutions who participated in NRG oncology to develop a study using either intensity modulated photons or intensity modulated protons to deliver 50.4 gray and 28 fractions to the lower risk CTV, essentially the gross tumor with an anatomically constrained 1.5 centimeter expansion, with a simultaneous integrated boost that was done in a phase 1 and then phase 2 fashion, where dose was sequentially escalated to this high-risk posterior margin from 60.2 to 61.6 to 63 gray and 28 fractions. The study actually started with protons. That was the first cohort to get started, and we were able to dose escalate that high-risk posterior margin to 63 gray. We did have one patient who had both ureters draped over inferior vena cava leiomyosarcoma, developed hydronephrosis in a retained ureter, receiving 57.5 gray. So we later reduced the dose to retained ureters to 50.4 gray. Phase 1 manuscript that was published in Advances in Radiation Oncology in 2017. 9 of the 11 patients went to surgery. 2 of the patients developed distant metastases. We've had only 1 local recurrence to date, and 7 of the 9 patients remain free of disease. And this just shows what that dose escalation looks like. Again, this high-risk posterior margin, which is the site of many of the retroperitoneal sarcoma recurrences after surgery alone. And this margin is, in fact, defined jointly by the radiation oncologist and the surgeon. And so, as I mentioned, the larger volume, 50.4 gray, and this high-risk volume went from 60.2 to 61.6 and finally 63 gray. Well, we did have one patient who did develop a late complication, developed a perforation of the second portion of the duodenum 7.5 years after completion of pre-op radiation. Was able to be repaired laparoscopically. In retrospect, that portion of the duodenum adjacent to the tumor received 60.2 gray. So just emphasizing the necessary care and trying to spare bowel in treating these patients. We then went on to perform the phase 2 study at the highest dose tested in the phase 1 study, 63 gray to that posterior target volume with a dose of 50.4 gray to the average risk CTV. Patients were recruited in Mass General, Mayo Clinic, and the MD Anderson. We completed an accrual of 60 patients in this phase 2 cohort, phase 2 intensity modulated proton cohort in 2021. At the time of the last analysis prior to ASCO 2021, where these results were presented, 51 of the patients had undergone surgery, 5 were awaiting surgery, and 4 had not undergone surgery due to the interval development metastases after preoperative radiation. With a median follow-up of 23 months, there were only 2 local occurrences, which is very encouraging. Nevertheless, these patients undergo major surgical resections. 2 patients who had IVC leiomyosarcomas, very challenging tumors, had a prolonged postoperative course. 2 patients had a perioperative death. One was pulmonary, not felt to be related to surgery, and the other patient had a duodenal ulcer. 1 patient had a late small bowel obstruction requiring surgery, and another patient had a late sigmoid colon anastomotic failure. Because of that, we subsequently lowered the colon and small bowel dose constraints to 52 gray max, so very conservative dose constraints. A couple of readmissions for either lymphopenia and pneumoperitoneum. 1 patient, interestingly, did develop a femoral neuropathy at 4 years after treatment. His femoral nerve was dissected off of the tumor. He was initially weak postoperatively, but he recovered. But this patient did have type 2 diabetes, and so we amended the protocol to reduce the CTV boost dose to 57.5 gray if in patients who were diabetic, to reduce the risk of neuropathy. The IMRT cohort started a couple of years after the proton cohort. It's a non-randomized study. It's really based on what technology the individual institutions have. But they were able to successfully perform the dose escalation to the same dose that was achieved with protons. These accrual was done at the Harvard institutions, Duke, Roswell Park, Rush University, and University of Utah. And the phase 2 study opened for accrual in 2018 at this dose of 63 gray, same dose that was tested with protons, and it's currently accruing at a number of institutions shown here. One of the other indications for radiation with protons is reirradiation. This is a 66-year-old man who was treated for Hodgkin's disease, 3,000 rats at age 16. And he, 50 years later, developed a grade 2 or 3 leiomyosarcoma, shown here, the tracheal bifurcation. He was treated with 4 cycles of adriamycin, ifosfamide, mesna chemotherapy, and then received 72 gray in 40 fractions with concurrent ifosfamide with a shrinking field technique, 50 gray to initial CTV, and then a boost to the tumor to 52 gray. And he has no evidence of local recurrence 4.5 years after his diagnosis. And he's NED. He did develop some sites of oligometastases that have either been resected or undergone SBRT. And Gutman et al. From the University of Pennsylvania Proton Center put together their results for reirradiation for sarcomas. And these were patients, 23 patients who either had radiation-associated sarcomas or had a local recurrence in a prior radiation field, and they were treated either neoadjuvantly, 50 gray, adjuvantly, postoperatively, 64.8 gray, or received definitive radiation. And the breakdown was 7, 8, and 8 in terms of the kind of radiation they received. Very respectable local control rate of 59% at 3 years, and encouragingly, no late grade 4 or 5 toxicities. And looks like the complications that they did see were relatively modest. One patient had a grade 2 lymphedema rate of 10%, 5% fracture rate, and a 5% fibrosis rate. So in summary, proton radiation is an increasingly important tool in the clinic for challenging sarcomas, since these tumors often require high radiation doses, often in combination with systemic therapy to large target volumes. Although there's no randomized data comparing photons to protons, the reduction in the integral dose can only benefit the patient. We do know that the relative benefit of proton versus photons is being studied in multiple randomized controlled studies in adults in the common tumors, and NRG Oncology has been a leader among others in pushing forward these randomized studies. Unfortunately, randomized trials are unlikely for most sarcomas because of the rarity, but nevertheless, the role of heavier charged particles versus protons is being studied for chordoma in randomized studies currently going on in Heidelberg. Thank you for your attention, and I appreciate the opportunity to attend your conference. Thank you.
So thank you, Professor Thomas. Well, it was an excellent coverage of everything, and it was a very good overview. Now, I just wanted to ask you one question, that in the light of his STRASS trial, as you have mentioned in your talk, do you think that proton can benefit patients with when we give in pre-operative settings? Because, we always wonder that with photon or proton, can we give preoperatively or only post-operatively we should give, in retroperitoneal sarcoma especially?
I think most people would agree, if you are going to do radiation for retroperitoneal sarcomas, that preoperative radiation is much preferred because the tumor pushes the bowel out of the way. The STRASS study does suggest, particularly for liposarcomas, that there does appear to be a local control benefit. And when you look at the patients in that study who underwent a gross total resection, 30 of the patients in the surgery arm had a local recurrence compared to only 12 in the patients who received preoperative radiation. So I think we'll need to see further follow-up on these patients, but it does look like there will be a benefit for the liposarcomas. In the study we're conducting in terms of dose escalation, we're looking at dose escalation with either protons or with IMRT, and I think we're going to have to see whether there's any benefit to protons. I think though logically that's a large target volume. Protons may offer a benefit, but you may be able to do similar dose escalation with IMRT. We'll just have to see what the results of the study show.
Thank you. And do you give some extra or boost doses to the posterior abdominal wall of margin, or like in primary, this you can include everything? Or you give some extra boost?
Yeah, that study we were conducting actually incorporates a simultaneous integrated boost to that posterior abdominal wall. And that margin, we sequentially escalated that posterior margin from 60.2 to 61.6, and finally 63 gray was the dose we settled on for the phase 2 study. So that posterior margin gets 63 gray and 28 fractions, where the rest of the tumor, which is essentially the tumor in about a 1.5 centimeter margin, gets 50.4 gray. And at least so far in the proton cohort, among 60 patients, 51 went to surgery, 4 were waiting for surgery, but with of those patients who'd gone to surgery, there were only a couple of local recurrences in 2 years. So we're cautiously optimistic.
Another question which comes in my mind, that advantage of proton in base of skull tumors is very well documented. But at the same time, I just wanted to ask you that what is your take on parameningeal site? Can we give extra dose or some dose escalation in these parameningeal sites of skull base area or this area?
In the parameningeal sites in the skull base?
Yeah, parameningeal. Yeah, like parameningeal. Can we do some dose escalation with proton?
I think so, and I think that some of those areas, the sinus tumors, I think are appropriate for protons. Again, you get better sparing of the brain parenchyma.
No, thank you. Anybody else?
Can I have a question?
Yeah.
Yeah, in most of your representative cases which you have shown, you seems to use only one direct or two direct beam. Okay, so did you observe any end range RBE effect in the critical organ? First question. And the second question is, what is your bowel management protocol?
Thank you. Using scan beam, we've tended to use more single or sometimes two posterior oblique fields. I think you can make an argument for using more than one field to avoid the potential end of range issue. That being said, I can't definitively say we've actually seen the end of range issues, but I think there are theoretical arguments for using more than one beam angle to reduce that risk. Our bowel constraints have generally been pretty similar to what have been used for conventional radiation. We've tried to limit small bowel to 50.4, except in situations where the tumor is abutting the bowel, we'll cautiously go up to 57.5 gray. And then for rectum, pretty similar to prostate constraints. The one issue being that in the sacrochordomas, you tend to treat a larger volume of rectum, but in general, we've not seen any significant late rectal bleeding in the majority of these patients. So in general, by essentially setting the anterior margin of the clinical target volume just up against the
I think,
rectum.
My question was about, because your target was putting with the bowel back, and bowel filling status and the bowel movements are going to change on daily basis. So what is the protocol to manage that in your center?
We, for the abdominal, particularly the retroperitoneal tumors, we tend to use posterior oblique and lateral fields and try to avoid anterior fields that are going through bowel gas.
So thank you for your wonderful talk, sir. I'm Dr. Vishnu. My question to you is, how many percentage of patients of these, especially large sacral tumors, had urinary involvement at presentation, and how many of them actually recovered once you gave your definitive proton? Because as a surgeon, once you do a sacrectomy, the urinary function for the patient is pretty bad. So I want to know what is the return of normal urinary function for the patient after therapy for this?
The patients, if they have lost urinary or bowel control at presentation, they virtually never recover in patients with chordomas because the chordomas regress so slowly. But in the patients in whom we have treated who have intact bowel and bladder function, I'm not aware of any loss of bowel or bladder function if they were intact at the time of presentation.
Okay.
So, Dr. Delaney, I have a question. Suppose you have a recurrence after proton therapy for sacral chordoma treated primarily by protons. How difficult it is to salvage it surgically if it is resected?
My experience is most patients who have a local recurrence of a chordoma, whether after surgery or after radiation, are rarely salvaged. We have occasionally done salvage resections in those patients, but the morbidity and the risk of wound healing is high. It's unfortunately a local recurrence, whether after surgery or after radiation, is very rarely permanently salvaged.
With this, I would like to thank Professor Thomas and for his excellent presentation. And we are going for our next presentation by Professor Eric on the late. We are already running late sometime. So late evaluation of optimization and other key advances in proton planning for Dr. Eric.
Thank you.
Yes, hello, thank you. Can you all hear me?
So we can hear you.
Excellent. So good afternoon or good evening. So this is Erik Traneus speaking from Stockholm, Sweden. So thanks for having us present at this meeting. So I will first, this is my disclaimer. So I'm an employee of research laboratories. So I will talk about LT optimization and a little bit about the RBE optimization and other advances in treatment planning for protons. And I will spend most of the time on the LT optimization part. And whereas other advances I will touch on very briefly only. And it's actually 3 items there. And one is that proton machine learning auto planning for protons is now in clinical use at a race station IBA site in Europe. So that's UMCG. So this is just since April. So that's will actually open up a new window to simplify and streamline proton planning. And I think this will eventually gain quite a lot of traction and become a routine clinical procedure. Second thing is proton arc planning, which I will go back to in one slide in a few minutes. And then also a little bit about conformal flash planning. So there's no way one can talk about protons these days without at least mentioning flash, so I will do that. But most of the time will be about LT optimization, and briefly a little bit why we should start to look into that. And a little bit about the challenges going forward. And then, as this is a practicum, I will actually dive straight into a clinical case to show you how LT optimization can be worked out and what the pros and cons are. And if you go to a webinar or dictionary, you'll see that a practicum is in fact a practical application of previously applied studied theory. So that's why I think it makes sense to actually work out LT optimization in a real clinical case. So this is a case we will look at. So it's a head and neck case, So there's a CTV, PTV, and the risk organ I will focus on is a chiasm here, but there are of course also other risk organs like brainstem and eye nerves. So this is treated with 3 beams like this. 2 of them are coplanar and 1 off coplanar beam. The primary risk organ I will focus on here is the chiasm. This is actually a real case. And what happened to this particular patient was that he or she lost the vision of the left eye. And the question asked was, why did that happen? And then one way to try to answer that is to see where the high LT goes, and also to evaluate if there is potentially a high RBE dose there. Of course, even if you find that high LT goes into the chiasm a lot in this case, there's no way, of course, you know that was actually the cause of this unfortunate toxicity, but that's at least one piece of the puzzle. So this is the case we will look at. And the way to do that is through a research version of RayStation with everything done with Monte Carlo, which is now in clinical release since 5 years. And most recently, we actually added LET visualization in RayStation in a clinical release. And the LET optimization, which is what we will look at, is still only in a research version of the system. So before diving into LET optimization, so one slide about proton arcs. This is something we have implemented in RayStation now. It's a project that has been going on for 2 years, and it will reach a clinical release by the end of this year. And it's released specifically to work with IBA proton delivery systems. And the motivation for arc planning is simply that you get improved conformality. There's also fairly efficient delivery because it's essentially like delivering a single beam only. So there is no need to spend time on switching beams and beam-specific QA and so on. It also simplifies planning because there is essentially no need to consider beam angles when you place your beams in traditional planning, because arc planning actually tries out next to infinite number of beam angles, or very many at least. So it's essentially free from beam angle considerations in initial plan setup. And moreover, you can also deliver, like with photons, deliver single or dual or multiple arcs with protons, which gives you increased conformality. So that's proton arcs. Flash is something we work on. We do that together with IBA. And the way forward for us is to go for conformal flash. And we do that by placing in the beam a maximally thick range shifter plus a 3D printed object upstream of the range shifter, which we call a hedgehog. So it's essentially a physical device that gives you the energy absorption and energy modulation needed to cover a target with a single energy layer in your PBS plan. And of course, the whole game here is to do this with a single energy layer to allow you to deliver the dose in less than a second, in contrast to classical IMPT plans where it may take half a minute or so. So that's what I would say about Flash. Now over to LET optimization. It's sometimes referred to as LET manipulation, sometimes LET painting, but it means essentially the same thing. And I prefer to actually say LET manipulation because that's what it's all about. So why should we bother about this? Well, with classical planning, you end up with a lot of the proton stoppers and the high LET in the distal edge per beam. And typically you may have risk organs near the distal edge. And then there have been numerous publications that highlight the fact that there are sometimes toxicities that kind of accumulate around the distal edge of proton beams. And the question arises, of course, is that related to high LET? And there is no clear answer now. There are some indications that it is, in fact, but there are also other indications that it's not really correlated to high LET. It's rather about spread of patient biological response. So the difference between individual patients is actually larger than the eventual possible effect of high LT or not high LT in a reading like the distal edge of a beam. So this is still a very open question. And in addition to that, with the protons, there is an issue of RBE, and the proton RBE modeling is not a high precision science, to say the least. We actually know the age of the universe with a lot better precision than we know proton RBE. And if you look at proton RBE models that have been published, there are quite many of them actually. Put them on top of each other. You see here a couple of figures from a couple of publications, and the spread between models is obviously large. So this is also one thing to be aware of. Now, LT manipulation. So there are essentially two reasons why one should do that. One is to reduce LT at the perimeter of the PTV to better control the organ at risk protection in cases where you have organs at risk near the distal edge. Second use of LT manipulation is to increase the LT inside the CTV or PTV to enhance the therapeutic effect. So it's actually two different motivations why one should consider to manipulate the LT. And a typical example of use case number one here, which is what I will illustrate later on, is where you have a PTV here and then the chiasm as a distal organ. And the green color here is a low LT, 2.5 kV to 3 kV per micrometer, which fills up the entire target. And then with the LT penalty, you're able to get this low LT volume to actually spread out through the entire chiasm, which is not what you would get with the normal way of treatment planning. And outside and distal to target and organ at risk, and you see very high LT values, but most of them are in regions where dose is low, so their high LT does not matter. But it of course matters in regions where there are still reasonably high dose, which means near the PTV in this case. So there are two situations geometrically. So there is, first one is case one here, is where you have two orthogonal beams and one of them is shooting towards the risk organ. Second situation is where they have two opposed beams treating a target surrounded by risk organ tissue. In the first case, if you optimize a uniform dose, which is what you have here, and then look at where proton stops, you find that most of them stops in the distal edge per beam. And in particular, on the horizontal beam here, we get lots of stoppers in or near the distal risk organ. And the corresponding LT distribution, of course, follows the proton stoppers. So you get the high LT distal to the target per beam. And then you get, in addition, high LT far away from the target and the risk organ, but that we can actually completely disregard because high LT at very low dose that have no clinical impact. Now, if you look at the profile along a horizontal line through the target, we see the dose, which is a solid line here. Here we are in the target, and then the dose drops off. And in this case, the risk organ starts about here, where the prescription dose starts to drop. And the corresponding track and LT distributions look like this, and both of them peak in the distal region, of course. And the LT stays high all the way through into the region with very low dose, and the track and distribution, of course, drops off together with the dose. And the take-home message here is that most of the protons actually stops in the risk organ. In this case, what we'll see later, the chiasm. And the corresponding LT value, of course, also peaks here. And what you also see that the LT is high in regions where the dose is still large compared to the prescription dose. And then, of course, when dose drops off, the clinical toxicity goes down, of course, but the LT still stays high. But that is not a concern because high LT at low dose is irrelevant. The other cases with two opposed beams, again, you get the stoppers in the distal edge per beam and the high LT in the distal edge per beam. And there is the corresponding profiles of those LT and track ends. And again, you see you get stoppers and high LT in the risk organ, distal to the PTV per beam. Now, we will take a close look at this for this case. And to do that, I will jump straight into TPS. So here is the case in RayStation. So we have the 3 beams, 2 coplanar beams and 1 non-coplanar beam. And I will now optimize a standard IMPT plan. So what we see here is the case with these objectives. And these are just standard physical or RB 1.1 dose objectives. So no LET penalty. So this is what you would get with in this case, a classical approach to proton planning. So I'm doing this now with Monte Carlo to compute the spotlets, and you see we have a super fast Monte Carlo, so it took us about 5 seconds to get 3,000 spotlets for this case, and now we're optimizing and running through about 70 or 80 or 90 iterations, and after that we have the final dose for this patient. Yes, so this is our, let's call it the baseline plan, only physical dose objectives or RB 1.1. And I will compute the final dose here. So that will give me LET, track and distributions, and also RBE dose according to a couple of RB models. And we will take now a close look at that. So I'm now displaying this with 3 dose windows, and I'm picking up some data like that. And we will look at this along a profile that goes through the target, through the chiasm, and then out on the other side of the skull here. So this is a dose. And in this case, the chiasm starts about here, where the dose starts to drop off. So through the entire drop-off area, in fact, inside the chiasm. And the first thing we should look at is where do the protons stop? And as we saw before on the slide, they in fact stop, most of them stops in the chiasm. And the corresponding LET distribution is actually like this. So you may not see the scale here, but this dashed line is LET. It's about 2.5 kV per micrometer in the target. And then it approaches 3, 4, 5, 6, 7 kV per micrometer when we go into the chiasm. So what we will do now is save this and go to another plan, which is this one. And we go back to the optimizer here. Now comes the nice piece of this pudding. Namely, this plan is identical to the previous plan. It's the same energy layer, same spots, same everything. Only difference is that I've added an additional objective function that acts on the chiasm in this case, and it penalizes LET in voxels where LET is above 3 kV per micrometer in this case. And I only care about that if the dose is also above a certain level, because high LET at low dose have little clinical impact. So there's no point in spending optimization power in reducing LET in low dose voxels. So let's see how this works out. I'm starting the optimization now. Again, with our super fast Monte Carlo, so we get the spotlets that now contains dose and LET information in about 7 seconds. And here now we're optimized, so this will run through 70 or 80 iterations. And then we have now a competing plan that we will put side by side with the baseline that we just looked at. And what we will find, if we go over to plan evaluation here. So now running Zoom at the same time as running heavy duty numerical computations may sometimes but all right, now we're done. So here is our LET optimized plan. So first thing to do is, in fact, to look at them side by side like this. So here is a LET penalized plan, and I will put down here the baseline plan. And if you look at the TVH, oops, sorry, that was the physical dose. We should go for. Yes. Top left is the LET penalized plan. Bottom left is the baseline plan. And if you look at our dose volume histograms, let's bring in the blue curve is the PTV here. And you see there's essentially no difference in between the two plans, unless we look extremely carefully, which we will do in the next minute. But from what you can see here, the two plans are essentially very similar. If you look at the dose difference, you see that there is actually a difference in this case between the chiasm and the brainstem, and we will come back to that. But first thing to do here is to pick up, get the final dose like that, to get LET and other things, and then we will take a look at that and compare the two plans. Again, we will look at this along this line that we looked at before that goes to target and chiasm. And the first thing to look at is the tractants. So what we see here is what we looked at before. Here we have the tractants for the baseline plan. And now comes an interesting piece here, namely the tractants for the LET penalized plan. And what you see here in the chiasm, we have a quite strong reduction in tractants. And of course, a consequence of that is that we have a corresponding dip in LET in the chiasm. So what we see here is, again, dose, that's a solid line, and we see LET. And when we go into the chiasm, we see that we are actually able to get the LET to even drop a little bit below what it was in the target. So here we are at LET values below 3 kV per micrometer, which is exactly what we asked for in the optimizer, compared to the baseline plan where LET actually jumps up to 3, 4, 5, 6, 7 kV per micrometer. So this is what you can do with LET optimization. Of course, LET is, there's no uncertainty in LET, it's just physics. So if you know how to compute those, you also have the LET with the same accuracy. So there's so far no uncertainty from biology and so on. So far we are on a, let's say, solid ground. If you look now carefully at this case here and look at, again, dose for the two cases, which we have here, we can take out the LET. So here we have the dose along this profile for the two plans. Upper left is a LET penalized plan, middle one is a baseline plan. The two dose curves actually fall, in this case, essentially on top of each other. You can barely see that it's actually two dose distributions. So this is how it looks like when we go through the chiasm. Now, if I grab this line and pull it down into this region where we can actually see a dose difference, we see that something happens here. The LET penalized plan have a little bit of excess dose, little bit downstream of the PTV along this line when it goes through a volume which is outside of the chiasm in this case. And this is a price you have to pay to reduce LET in the chiasm. We still want energy and dose to be deposited in the PTV near the chiasm. So there still has to be protons that pass by the chiasm. And in this case, what happens is that the spot weights from this beam primarily are actually increased to still give you energy in this region of the PTV. And as a consequence of that, the spot weights from the other two beams that actually are distal to the chiasm in this case are reduced. But the protons have to stop somewhere, and there is always a price to be paid for playing around with LET, and in this case it happens exactly here. If you look at the DVH curve here, sorry, if you look at the DVH in this region, now we will actually bring in another dose here. wants to make this. Yes. So here, if you look at the DVH curves and look at a volume, which is the brain minus a CTV, and take away all other curves here to make it clear. So this is a DVH curve of the volume of the brain minus CTV in this case. And this a little bit excess dose that you see, this is outline. The excess dose that you see outside here is really small if you look at it from a DVH from the entire brain. So whether this is a better plan or a worse plan is something that is up for discussion. And this is what we think is the next big step in advancing proton planning. Namely bringing in these degrees of freedom, and then it's really up to physicists and oncologists to find out where is the balance between starting to manipulate LET, where you win something, but on the other hand, there's always a price to be paid. So exactly where that balance is not clear, I think, and this will be exciting to find out how this moves forward. Finally, I want to show you something that relates to RBE. So I will bring in the RBE factor along the same line. So I'm picking now RBE factor from the McNamara RBE model for the baseline plan. And here is the McNamara RBE factor for the competing LET penalized plan. And if you look at that closely, we see here that in terms of RBE, so these two lines, dashed and dotted, shows the RBE factor according to one particular RBE model I picked. And you see the difference is, of course, here in the chiasm, and it's about RBE factors. Here the RBE factor is 1.22 with the LET penalized plan, and with the non-LET penalized plan, it's about 1.32, which means that there's about a 10% difference in RBE dose, at least according to this RBE model. So that's how much this matters in terms of dose, in terms of RBE dose. So I think I stop there. There's a lot more to say, but I will go back to here, and this is my final slide. In conclusion, LET visualization is available now for clinical use. LET manipulation is available for exploration and research. There's also a proton ML planning in clinical use now. ARC planning will come by the end of this year, and conformal flash is works in progress. Finally, I want to highlight that at PTCOG, if you go there, we have a pre-meeting that we invite you to attend. It's the day before PTCOG starts from 10 to 4 p.m. on Tuesday, June 28th. So thank you for your attention.
With a constant time, we are very thankful to Professor Dr. Eric to put the present condition of the planning and what will be the advancement in due course of time. With the time constant, we can take only one question.
Thank you very much for your talk. I just want to, so you were shown from the anterior beam, right anterior beam, the contribution was high, correct? So if usually we know this phenomena, so what we usually do, we always give a robustness to the chiasm so that it will reduce the LET effect. So instead of using the LET optimization and use the already available robust optimization so that you reduce it and reduce the LET effect. So what is your opinion about that?
Oh, okay. So that's a very good question, actually. So I didn't even mention robustness here because lack of time. But penalizing LET in the distal risk organs pushes the plan in the same direction as a robust optimization would do. But it turns out, I have looked a little bit into this, and it turns out the robust optimization itself is not pushing LET out of the risk organ a lot. It pushes out dose, but both low LET dose and high LET dose. So it does not end up with the same, let's say, strong reshuffling of spot weights. So to get to that point, you really have to push robust optimization quite far, a lot further than you would do in a normal case. That's my experience so far. But as I said, LET optimization is a fairly new thing. There's not many people that have had access to treatment planning with LET degrees of freedom. There are, of course, academic institutions like MD Anderson, Mayo, and so on that have in-house systems, but it has not yet been brought out onto a broader part of the proton community. But that is now happening, and it will be extremely exciting to see what happens and where this goes, and where we are in, let's say, 3 years' time.
Can I have one more question?
I will accumulate the whole timing in the
Okay, thanks.
we can have it in number of questions. So we are sincerely thanking you, Dr. Eric, and with closing this one and going for the next and the last talk of this session, which is Dr. Mark Mishra, generating evidences and optimizing patient selection for proton therapy for prostate cancer. I have to be really tight because otherwise the time will go to the next session. It will affect all the other sessions. So I'm sorry, but
Good evening, and thank you to the symposium organizers for the opportunity to speak and present today. My name is Mark Mishra from the University of Maryland. I'll spend the next few minutes discussing the role of proton therapy for management of prostate cancer. I have no disclosures to report. As many in the session here today can appreciate, the topic of proton therapy has been and continues to be the major focus of a public health policy debate, with the use of proton therapy for prostate cancer specifically being one of the most controversial topics in radiation oncology, which is especially relevant given that this is the most common disease site treated with proton therapy in the United States. While proponents of proton therapy point to an improved dose distribution to the rectum and bladder as sufficient justification for protons, others point to the overall lack of high-quality comparative effectiveness data, coupled with a significant increase in cost, while also pointing to the now excellent outcomes that are seen with IMRT and VMAT, which can be further improved in the spacer era. Given the long-term use of proton therapy for prostate cancer in the United States, there are now multiple long-term studies that demonstrate efficacy of proton therapy. But the relevant question at hand in the healthcare environment today is not does proton therapy work, but rather, does proton therapy provide any incremental benefit over standard radiation modality for prostate cancer patients? So first, how do we define incremental benefit for prostate cancer? Well, one, for localized disease, where prostate cancer is commonly treated with proton therapy, we know there's no difference in survival or even prostate cancer-specific mortality when we treat or we don't treat, as demonstrated in the PROTECT study. Therefore, any treatment modality that seeks to improve outcomes for prostate cancer patients must demonstrate either improved quality of life or a maintained quality of life with increased patient convenience. Before we get into the details of proton therapy, let us review what we know about prostate cancer patients' quality of life. First, from the PROTECT study, we know that both surgery and radiation therapy impact patient quality of life, but in a distinct pattern. Prostatectomy, as shown here in the panel on the left, results in higher levels of urinary incontinence as well as erectile dysfunction. Radiation therapy, on the other hand, results in more urinary irritative symptoms, but not incontinence, and also results in more bowel changes that results in increased bowel frequency, as well as the possibility of bloody stools. With this as the framework, can advanced radiation technology help reduce patient side effects? The PROTECT study, which was done in the 3D conformal radiation therapy era, whereas now the standard of care is at a minimum IMRT. So is there any data that improvements in radiation technology leads to improved patient outcomes? The best data to support an incremental benefit with IMRT compared to 3D conformal radiation therapy comes from a pre-planned analysis of RTOG 0126, comparing outcomes for men treated with high-dose, conventionally fractionated radiation therapy with 3D or IMRT. The results of this analysis were presented at the plenary session at ASTRO several years ago and showed a significant reduction in grade 2 and higher, but not grade 3 and higher, acute GI and GU toxicity. Long-term, grade 2 and higher toxicity was also improved with IMRT, as shown in the cumulative incidence curve shown here, with there being an absolute reduction of about 7% in overall toxicity rates associated with the use of IMRT when compared to 3D. Looking at GI toxicity alone, long-term toxicities were rare, and there was only a trend towards improvement with IMRT. While it's encouraging to see improvements in clinician-scored toxicity, the focus now in oncology is on improving patient-reported outcomes, and not so much clinician-scored toxicities, which we know often underreport toxicity profiles when compared to those reported by patients. RTOG 0126 did in fact collect PROs using a tool that was created by Deb Bruner, known as the FACE tool, and when comparing PROs for the same patient population that showed differences in clinician-scored toxicity, there was in fact no difference in patient-reported outcomes between men treated with 3D or IMRT. So as we're reviewing currently available data with proton therapy, and as new data becomes available in the coming years, it's important for us to keep this data in mind, which serves as a useful framework. Now, moving on to proton therapy, there have fortunately been a number of studies evaluating comparative toxicity and patient-reported outcomes for patients treated with IMRT or protons. Here's an example of a nice study done by Brad Hoppe at the University of Florida comparing patient-reported outcomes using the EPIC questionnaire and comparing outcomes for patients treated with protons at the University of Florida versus patients treated with IMRT in the PROST-QA study. In this study, patients treated with proton therapy were on average younger and more likely to be white. When comparing EPIC bowel, urinary, and sexual summary scores for patients, as shown here on the right, both treatments resulted in quality of life changes, but there was no overall difference in summary scores for any subscale at any time point associated with protons or IMRT. While there were no differences in summary scores, there were, however, differences in outcomes when looking at some of the individual attributes that are included in the bowel subscale for EPIC. For example, for bowel frequency, patients with proton therapy were less likely to experience any moderate or big problem with bowel frequency when compared to patients with IMRT at the 2-year time point, with that number being 3 versus 10% at 2 years. Patients treated with protons were also half as likely, 7 versus 15%, to experience a moderate or big problem with bowel urgency at 2 years when compared to those men treated with IMRT. Stool incontinence was fortunately rare for patients treated with both modalities. On the flip side, patients treated with proton therapy were more likely to experience some level of rectal bleeding compared to patients treated with IMRT, 32 versus 19%. The study presented by Brad Hoppe was for patients treated with conventionally fractionated radiation therapy, whereas now, in 2022, the standard of care is hypofractionated treatment. So here's a study, a multi-institutional study presented by Nehal Vapivala, comparing outcomes for patients treated with hypofractionated protons compared to hypofractionated IMRT, and again found no difference between proton therapy and IMRT with regards to high-grade toxicities. While all of this data gives us an existing framework to help inform patients about the role of proton therapy, it ultimately underscores the need for a randomized study, which has now fortunately been done. The Particle or Prostate Advanced Radiation Technologies Investigating Quality of Life study is a phase 3 study of proton therapy versus IMRT for patients with lower intermediate risk prostate cancer that's being led out of MGH by Jason F. Stadio. In this study, patients are randomized 1-to-1 between IMRT and protons, and the primary endpoint of this study is 24-month bowel summary score changes compared to baseline compared between the two modalities. Patients are stratified according to intention to use of hydrogel rectal spacer and use of hypofractionated radiation therapy. This study, which took nearly a decade to accrue and and was open at multiple centers, including the University of Maryland, I'm pleased to say is now completed to accrual as of the end of 2021, and results for this study are expected to be presented in late 2023 or early 2024. A parallel study that's being conducted in the United States is a pragmatic study that's being led out of the University of Florida by Nancy Mendenhall, and it's being done with input of patients, also comparing protons to photons, but in a non-randomized fashion. This study has two parallel cohorts with the same inclusion criteria. There's an IMRT cohort that can be opened at photon-only centers, even those without any affiliation with a proton center, where patients will be followed before treatment to after treatment with serial quality of life questionnaires. And this portion of the study has an aim of enrollment of 1,500 IMRT patients. In parallel, there's a proton cohort, which will also enroll 1,500 patients. But in the proton cohort, there's an embedded randomized study in which patients will be randomized to standard versus hypofractionation. This study will provide definitive evidence that there's no increased risk, or answer the question of whether there's any increased risk with prostate hypofractionation with proton therapy, which some centers often worry about, and will also importantly provide for a non-randomized comparison of IMRT versus protons that will complement the particle study. A strength of this study is that it also allows for a variety of fractionation schedules, which are now commonly used in the United States and in Europe. And this study also includes some patients that will be receiving pelvic nodal radiation therapy. A couple comments I have for things to keep in mind as we get data from these studies and we design future studies. We know patient-reported outcomes are a vital endpoint for any oncology clinical trial. But we also need to look at the tools we're using as well as our methods of analysis in order to ask whether or not we're asking all of the relevant questions. For example, the epic bowel subscale, which is the primary endpoint of the particle randomized study, consists of 5 items in the bowel subscale: frequency, urgency, pain, bloody stools, and incontinence. The current method for evaluating PROs, such as the EPIC score, is to average patient responses across all of these attributes to generate a subscale summary score. This method assumes that each side effect is of equal significance to patients. And of note, we know from the University of Florida study, which I presented earlier, that even when summary scores are not different, there are differences in outcomes with each of the attributes. We had previously conducted a study at the University of Maryland in collaboration with the University of Florida to perform a conjoint analysis specific to the epic bowel summary subscale to generate patient preference weights for each of the different attributes that are included in the bowel summary score. I won't go into details of the methods of conducting this conjoint analysis, also known as a best-worst case 2 study. But as you can see here on the right, when the study was completed, we found a significant variation in patient preference weights for each of the different attributes. Patients gave the highest weight to wanting to avoid incontinence, followed by stool urgency, and gave the least weight to bowel frequency. Based on our analysis, we proposed a different weight to be given in the summary subscale scores as shown here. Currently, each of these items is weighted at 20%, but based on our analysis, we proposed differential weighting with incontinence having a score of 30% compared to frequency having a score of 13% based on those preference weights that we elicited. Now, this does need to be validated in different cohorts, but analyses like these can be embedded into studies, especially randomized studies, to determine patient preference weights for those patients who participate in the trials and experience those toxicities. And hopefully, doing an analysis with and without patient preference weights will help us provide a more well-rounded interpretation of data for patients. Analyses such as these are now starting to also be used in medical oncology and can be considered during the FDA review of different drugs and devices. Another thing I wanted to mention is just like we shifted from 3D to IMRT in the photon world, we're now shifting from passive scattering to pencil beam scanning in the proton world. The hope is that pencil beam scanning is going to allow for improved outcomes and an even more conformal dose distribution. However, there are also preclinical studies that have indicated there can be LET and RBE uncertainties that may be exacerbated when using pencil beam scanning. And given that patients participating in studies like the particle study could be treated with either modality, this may have an impact on the results of these ongoing studies. We did do an analysis using the PCG registry, comparing outcomes for patients treated with pencil beam versus passive scattering, and surprisingly found that acute grade 2 and higher GU toxicity was more common with pencil beam scanning than it was with passive scattering. However, we found no difference in long-term toxicity. We saw a similar pattern when looking at PROs, with pencil beam patients reporting more changes in EPIC urinary function subscale scores at 1 year compared to those treated with passive scattering. This data is far from definitive, but I only mention this because I think it's something important that we need to look at in the context of the studies as they're being conducted and presented. Now, how about other applications of proton therapy for prostate cancer, such as SBRT? The data for photon SBRT has been very promising and is well received by patients and physicians alike who appreciate the ability to complete treatment in a shorter period of time. So 1, can SBRT be done with protons? The answer is, of course, yes. And this is something that we now routinely do in our practice at the University of Maryland for patients who are candidates for SBRT. I personally have been pleasantly surprised with the proton plans compared to photon plans. The treatment in this case is still done with 2 opposed lateral beams. Typically, in my experience, it's difficult for a proton beam therapy plan to beat the conformality and dose fall-off of a photon SBRT plan. But a key difference with prostate SBRT is we don't heat up the center in order to minimize urethral toxicity. A prostate SBRT plan will typically have a hotspot of less than 105%, compared to SBRT that's done in other sites for lung or brain, where with photons, we typically aim to have a hotspot of about 120%. This ultimately limits the dose fall-off and dose gradient with photons. With the comparative plans that I've done so far with protons SBRT versus photon SBRT, I've often found a better dose fall-off with the proton plans, resulting in an improved dose to the rectum and bladder. While I know that there are concerns at some centers for using hypofractionation for prostate cancer treatment with proton beam therapy, it's important to know that there's high-level data to support the safety of protons for prostate SBRT, namely through the PCG GU002 study, which was a randomized study for patients with low-risk disease, comparing conventionally fractionated treatment, 44 treatments, to proton SBRT in 5 fractions. Interim results for this study were previously published in 2018, and 5-year results of this study were also recently presented at ASTRO last year, showing no difference in high-grade GI or GU toxicity, which were rare with both fractionation schedules. While I focus mainly on treatment of the prostate alone in the slides presented earlier today, with data from the POP-RT study, as well as now the RTOG 0534 study, pelvic nodal radiation therapy is here to stay and will likely have a growing role in prostate radiation treatment. There's limited data for proton therapy with pelvic nodal radiation therapy, but this is commonly done at centers across the United States. Here's one study that was done through the Proton Collaborative Group, which showed low rates of acute GI as well as GU toxicity, with GI toxicity being less than 5% for patients treated to their whole pelvis along with prostate using proton therapy. In general, I do think proton therapy has a role for pelvic nodal radiation therapy. I always tell my residents, the bigger the target, the bigger the theoretical benefit of protons. And in this case, reducing some of that low and moderate dose to the bowel can, in my opinion, reduce patient side effects. A study that we're doing here at the University of Maryland with pelvic nodal radiation therapy is a phase 1 dose escalation study of hypofractionated accelerated pelvic nodal radiation therapy delivered with an SIB boost for patients with localized, intermediate or high-risk prostate cancer requiring pelvic nodal radiation therapy. This study is evaluating a progressively more hypofractionated SIB schedule, going from 20 fractions to 16 fractions, followed by 12 fractions, with a progressively higher BED to the tumor, while maintaining the same BED to the normal tissue. The study is designed as a 3+3 phase 1 study, and we've completed accrual to dose level 1 as well as 2, and we'll be opening dose level 3 in the coming weeks, and hope to present the results of this study in about a year. So how do I help decide who I should and should not treat with protons for prostate cancer? For patients with intact disease, where I'm treating the prostate or prostate with seminal vesicles, 1, we always recommend clinical trial participation for patients who are eligible. 2, we favor protons for any of our younger patients. And 3, for all other patients, we have an honest conversation with the patient about what we know and what we don't know about photons compared to protons, and help make a shared decision with the patient about which treatment would be best for them based on their preferences and the available data. For patients who are SBRT candidates, we always do a comparative plan. If the dose distribution is similar, VMAT is preferred, but as I mentioned, proton plans often give a superior plan, and in many cases, we end up using proton therapy. I did not discuss hydrogel rectal spacer in this lecture, but for all of our patients with intact disease, we strongly encourage the use of hydrogel rectal spacer. We do not use balloons. However, for SBRT patients, we will only do SBRT if the patient has a hydrogel rectal spacer. For patients requiring pelvic nodal radiation therapy, as I mentioned, I do favor protons for patients in this indication. However, I also want to mention that for patients with high-risk disease, when we are treating the nodes, we always favor performing the prostate boost with brachytherapy and not with protons if the patient is a candidate based on the ASCEND-RT study. I did not have time to touch on post-prostatectomy radiation therapy in detail. However, the benefit of protons, in my opinion, can be less pronounced in the post-prostatectomy setting when treating the fossa alone, namely because the bladder is intentionally included in the volumes as you move inferiorly below the symphysis. And of course, you cannot use a spacer in the post-prostatectomy setting. However, for patients who are receiving nodal radiation therapy, which will likely become more the norm given the results of RTUG 0534, I will use protons when treating the fossa as well as the lymph nodes. But again, this is a case where daily cone beam CT is mandatory due to the day-to-day changes that can happen with the rectum. I also wanted to take a minute to discuss some of the points, some of the downsides specifically of protons that I try to mention to my patients. 1, protons are very sensitive to changes in anatomy, which may require replanning, and depending on the significance of these changes, require a small break in treatment. 2, treatment times are significantly longer with protons. At least at our center, it can be anywhere from about 30 to 40 minutes, compared to less than 10 minutes when patients are treated with VMAT, which can be a big difference from the patient perspective, especially towards the end of treatment when patients have a hard time maintaining a full bladder. And 3, no matter how experienced your team of physicians or physicists or who your vendor is, there's unfortunately always the possibility of downtime with proton therapy, which we typically don't see in the photon world. This can be very frustrating for patients if it does happen while they're under treatment, and there's now some newer data showing a possible detriment for patients with high-risk disease who have a significant break in their treatment. In summary, there is a growing body of evidence comparing protons to photons for patients with prostate cancer. There does not appear to be any detriment with treating with protons, and the superiority of protons compared to photons has been formally tested in the now completed particle randomized study, which will be complemented by the COMPARE study, which is still ongoing. As we discussed today, the decision to treat with protons for prostate cancer is not a straightforward one, but as with all prostate cancer treatments, this should be the result of shared decision-making between the patient and their physician and include an honest discussion with the patient about what we know and don't know about photons compared to protons. SBRT can be safely done with protons and is now supported with long-term follow-up data from a prospective study completed through the Proton Collaborative Group. Finally, future studies should incorporate novel PRO analysis methods and also evaluate if differences in proton technology impact patient outcomes. Thank you again for your attention and the opportunity to present here today at Apollo.
Yeah, I think it's nice presentations covering all the potential of, and even the disadvantages of protons. I have a small doubt. I think you did say that GI toxicity between the double scattering and the pencil beam scanning technique was significant. And I'm just wondering why it is, because with the double scattering, the advantage what you are getting is only the lateral penumbra. And as far as the prostate is concerned, the energy modulation is very, very minimal. So from both the sides, the dose towards whether we use a IMPT or double scattering, the energy perturbation or energy modulations is very minimal. So why I think you see I'm just wondering how come the GI toxicity is more with the IMPT. So in that case, should we treat all of our patients with the SFO? But even in IMPT also, I still wonder why the energy modulation should be so high for a prostate.
Thank you for the question. Just to clarify, so it was a GU toxicity, acute GU toxicity. GI toxicity was not different between pencil beam scanning and passive scattering. So that was a surprising finding. Our center at University of Maryland, we only have pencil beam scanning, so we don't even have passive scattering at our center. So we are collecting DICOM images from the centers that participated in that study to look at dose volume changes that might help explain the finding or differences between the centers. But there, again, can be RBE or LET uncertainties that may be greater with pencil beam scanning. There is some data from MGH that has shown a slightly higher LET at the distal range for pencil beam scanning. Harold Paganetti and the group at MGH, again, have published quite a bit on that. So I think that's something that we'll have to look at further. Again, all of the ongoing studies allow for passive scattering or pencil beam scanning, and it's not a stratification factor. So I do think that it's something that we'll have to keep in mind as we're getting data from these studies and see if there is any difference between the two. And again, that data is not definitive, it's just hypothesis generating, something that I think we need to keep in mind.
Dr. Mishra, excellent talk. I have two quick questions. I was very curious when you said the SBRT proton plans were surprisingly better in many patients. Where did you find the advantage to be? Is it in the high dose region? You mentioned that you didn't have to give hot spots in the prostate to actually have a very sharp dose fall off, I guess. That's what you mentioned. But where did you find the real advantage in terms of dosimetry in SBRT with protons? And the second question is, are you evaluating hypofractionation in the postoperative setting as well with protons?
So one for SBRT, so what I meant was when we're doing photon-based SBRT, we don't heat up the center. So the dose follow-up that we typically see in our lung or CNS plans, we don't see with the prostate plan. So with the proton plans, when we looked at the conformality and the dose follow-up, looking at the 50% isodose line, that has been better in many cases with protons. And also given a better dose distribution to the bladder and to the rectum. It is on a case-by-case basis of patients with a smaller prostate. It's maybe not as pronounced of a difference, and those are the cases where we tend to use photon-based SBRT, but in those bigger targets, we tend to see a bigger benefit. And those are the ones that we are treating now at our center more commonly with protons. Other centers are also using a similar approach. I know at Mayo, they are routinely now doing SBRT with proton beam therapy for prostate. And to answer your question about hypofractionation, We have not started using that yet. I know there was, of course, the RTUG study that was done and was presented last year showing promising data with photons. We have not started using that in the postoperative setting for adjuvant or salvage plasma treatment.
Dr. Munish, I think we need to close the session because we're already running late by about 10 minutes. If it is all right, we would like to close the session.
This was a nice talk, and we are already late by 15 minutes. So thank you again to all of you, and thank you all the speakers. I'm handing over to Dr. Srinivas for further.
Thank you all the chairpersons for joining in and conducting this session